All right, welcome. Today, we're putting on our detective hats to tackle one of the biggest challenges you'll face in medicine, diagnosing heart failure. Think of this as a masterclass in clinical investigation, and we're going to break down the whole process clue by clue. So, first things first, heart failure isn't just one single disease. It's what we call a complex clinical syndrome. And those words really matter. It means the heart is failing at its fundamental job, getting blood to the body, or it's managing to do it, but only by cranking up the internal pressures to really dangerous levels. Your job is to solve the puzzle of why this is happening. And this is where the case always begins, right? A patient comes in and they just can't breathe. It's one of the most common things you'll ever see. So, is this a lung problem, like pneumonia? Or is this the first sign that their heart is in serious trouble? That's the core mystery you have to solve. To get to the bottom of it, we're going to follow a classic investigative path. First, we'll open the case file. Then we'll gather testimony by taking a really good patient history. After that, we examine the scene with a physical exam, send some evidence off for lab analysis, and finally, we'll put all those clues together to crack the case. Okay, let's start with step one, opening the case. Before we even start looking for clues, we have to understand the ground rules of this investigation. And here is the absolute most important rule of all. There is no single easy test for heart failure, no gold standard. It's a clinical diagnosis. That means you are the detective. You have to be the one to put all the pieces together, the patient's story, what you find on your exam, the lab data, to come to the right conclusion. All right, phase two, it's time to gather testimony. Honestly, the patient's story is probably the most important source of clues you're going to get. It tells you everything about how this started and where to look next. Now, what's fascinating is how the timeline completely changes the story. When it's an acute thing, happening over just days or weeks, patients give you those classic symptoms. They're short of breath, they can't lie flat, that's orthopnea, or they wake up in the middle of the night gasping for air. But if it's a chronic case that's been creeping up for months, the symptoms can be way more subtle. They might just complain about being tired, not feeling hungry, or some swelling in their legs. So let's talk about how strong our clues are using sensitivity and specificity. Dyspnea, or shortness of breath, super high sensitivity, 89%. That means almost everyone with heart failure has it. It's a great screening clue. But its specificity is kind of low, only 51%, because a million things can make you short of breath. Now look at orthopnea. Less sensitive, sure, but a specificity of 89%? That's powerful. If a patient tells you they have to sleep propped up on 3 pillows, your suspicion for heart failure should just shoot through the roof. So, we've gathered our testimony. Now it's time to examine the scene. The physical exam is where we look for hard, objective evidence to back up the patient's story. We can use the exact same framework here. Swelling or edema is pretty common, but not super specific. An elevated jugular venous pressure, the JVP, that's a much better clue. But then you have the S3 gallop. Look at that sensitivity, just 11%. It's really rare, you won't hear it often. But if you do, with 99% specificity, it's about as close to a smoking gun as you can get for ventricular dysfunction. And speaking of a smoking gun, let's talk about a clue that is so specific, it's considered virtually pathognomic. That's a fancy way of saying, if you find this, the case is pretty much solved. It almost definitively points to severe left ventricular systolic dysfunction. So what exactly is this thing? Pulses alternance is when you feel the pulse and there's a beat-to-beat change in its strength. You'll feel a strong beat, then a weak one, then a strong one, then a weak one. It's this very distinct pattern that tells you the heart is really, really struggling. It's a subtle but incredibly important sign. Okay, we've interviewed our witness and examined the scene. Now it's time to send the evidence to the lab. Our initial tests are going to help us build an even stronger case. So these are your go-to tools right out of the gate. An ECG to check the heart's electrical system, natriuretic peptides, which are hormones the heart releases when it's under stress, some basic blood work, and of course, a chest x-ray to get a picture of the heart and lungs. Now, the ECG is amazingly useful. But you know what? It's often most useful when it's completely normal. A clean ECG has a 98% negative predictive value. That means if you see one, it's super unlikely that your patient has severe systolic heart failure. It powerfully points your investigation in a whole other direction. So what about those natriuretic peptides? They're one of the most important blood tests we have in this situation. So how do these hormones, BNP and NT-proBNP, actually help us nail down the diagnosis?
Well, a lot like the ECG, the biggest power of the BMP test is in ruling things out. If your patient is short of breath, but their BMP level is less than 100, well, heart failure becomes a very, very unlikely suspect. It's an incredible tool for helping you know if you're barking up the wrong tree.
Now, the other marker, NT-proBNP, is what we often use to rule the diagnosis in. But here's the catch. You have to adjust for age. Look at how those cutoff numbers climb. A value of 500 might be really concerning in a 45-year-old, but pretty unremarkable in an 80-year-old. You've got to remember to make that age adjustment. All right, we have everything. We've got the patient's testimony, we've examined the scene, and we have the reports back from the lab. It's time to put it all together and crack this case. And this is where the echocardiogram comes in. It's our #1 imaging test. It lets us literally see the heart in action, measure its function, like the LVFF, which is how much blood it pumps with each beat. But remember that first rule we talked about? The echo gives us critical info, but it does not diagnose heart failure by itself. The diagnosis is, and always will be, clinical. So here's how the whole investigation flows. You start with your history and exam, you get your initial labs and x-rays, then you order that echo to look at the heart's structure and function. And then comes the most important step, synthesis. You step back, look at all your evidence, and search for those high specificity clues. If you find just one of those in a patient with a consistent story, you've got it. You've diagnosed heart failure. And these right here, these are your slam dunk clues. Any one of these, from orthopnea in the patient's story to that S3 gallop on exam, or seeing fluid in the lungs on the chest x-ray, any of these makes your diagnosis of heart failure extremely likely. Now, what about those really tough cases? The ones where all the clues are just not adding up? Well, for those, there is a true gold standard. It's an invasive hemodynamic exercise test. This is where a specialist actually threads a catheter into the heart to directly measure pressures while the patient is exercising. It's the ultimate tiebreaker when nothing else is clear. So you did it. You gathered the clues, you connected the dots, and you cracked the case. You've diagnosed heart failure. But, for any good detective, solving one case just opens up another one. You know what your patient has, but now the real work begins. You have to solve the next mystery. Why? What's the cause? Because that is the next step in actually helping your patient.